discussion is adrenal tumors. It's a very broad topic that will include both the benign and malignant diseases, and that also from the adrenal cortex as well as adrenal medulla. So to start with, what will go into a specific approach, we'll try to see the pathology, clinical features, diagnosis, and treatment on the basis of whether it is a medullary tumor or it is a cortical tumor. So adrenal tumors can be a primary. Is my screen visible to all?
Yes, sir, visible, sir.
Or it can be a secondary tumor. So primary tumor can be of cortex or can be from medulla. As you all know, there is GFR in the cortex, granulosa, fasciculata, and reticularis. So from G, that is salt, sugar, that is glucocorticoid, mineralocorticoid, and from R, reticulosa, there is a sex steroids that are secreted. So now, most of the common tumor of cortex are either a adrenal cortical adenoma, which will designate as ACA, or a adrenal cortical carcinoma. From medulla, it can be a pheochromocytoma. And if this pheochromocytoma arises from extra-adrenal source, that will be called a paraganglioma. So I think all of us is clear with this nomenclature. The secondary tumors can be from lung, melanoma, breast, etc. So, if we see the clinical features of grossly of adrenal tumors, it can be 3 types. Either it can be due to a hormone overproduction, or it can be due to some mass effect, or more commonly it presents as a incidental, which is diagnosed during routine scanning or routine imaging of some other causes. The hypothesis behind the adrenal tumor is the differentiation between the malignant adrenal tumors from the benign adrenal tumor is very difficult, because first of all, primary adrenal malignancies are very rare. And there is overlying clinical features of benign, and so if you don't find any metastasis, if it is a localized disease, it's very difficult to distinguish other than the histopathology from radiologic preoperative diagnosis whether it is adrenocortical adenoma or adrenocortical carcinoma. That is become very difficult without a proper histopathology on the post-op. Many times we cannot conclude that. So the management of both of this is quite similar. Now, if we come to the demography of these tumors, so adrenal tumors or adrenal cortical carcinoma has a bimodal distribution. So cortical tumors has a bimodal distribution. One is the early childhood, that is mostly syndromic one, or it can be in the older age, 5th or 6th decade. So many a time this childhood adrenocortical tumors are associated with germline mutation of different familial syndrome, and among them most common is Lee-Fraumeni, that is your TP53. And among the childhood adrenocortical tumors, around 80% there is a TP53 mutations. Other than this, there can be a Lynch 2, that is due to your CCC, or there can be MEN1 or FAP. So these are the syndrome which are usually found along with the adrenocortical tumors. I'm talking about the cortical tumors, not the pheochromocytoma. And if we talk about this pheochromocytoma, ACC or ACA, if we talk about this pheochromocytoma or paraganglionoma, 30% of them are syndromic, And the most common syndrome are obviously MEN2, VHL, von Hippel-Lindau, neurofibromatosis 1, and pheochromocytoma paraganglioma syndrome. Pheochromocytoma paraganglioma syndrome 1, 2, 5. So these are the syndrome which are associated with pheochromocytoma. And it has seen that the average age for pheochromocytoma is a 44 years. So it is a mostly middle life malignancy. Now, among this all pheochromocytoma, around 20% are malignant. And among these malignant tumors, around 50% have SDHB mutation. That is called pheochromocytoparaganglioma syndrome type 4. Now, if you come to the pathology, so it's, as I've said, in absence of histopathology or in absence of definite metastasis, it is very difficult to differentiate between adrenal cortical carcinoma and adrenal cortical adenoma. So, in pathology, if metastasis is not present, we use different criteria to classify it whether it is a carcinoma or adenoma. So the name of one such famous criteria is a WHIZ criteria. This can be a MCQ. If the WHIZ criteria is greater than 3, is equal to 3, so there is a chance that the lesion is malignant. Other than that, Ki67 is also used if it is more than 10%, it is suggestive of a malignancy, and the mitosis rate, if it is more than 22 per 50 high power field, the chances of malignancy is very high in the cortical tumor. Cortical tumor can be defined molecular subtype COC1, 2, or 3. Among them, these 3 is mostly malignant tumor. So all the pathology, all the diagnostic tools are approached towards whether it is a malignancy or it is a benign disease to differentiate between them. When it comes to the pathology about pheochromocytoma, the same happens. Differentiation between this malignant and a benign pheochromocytoma is almost impossible. Though there are some suggestion that if it is more than 5 centimeter, which is extra-adrenal, if there is a SDHB mutation, so these are suggestive of malignancy. But as a whole, there is no histological criteria. As we have WHIZ criteria for adrenal cortical tumor, but there is no histological criteria to differentiate between benign versus malignant. So no standard histological criteria. Though people have tried to derive many criteria like PASS, that is pheochromocytoma of the adrenal gland scale score, or a GAPP score, that is grading for adrenal pheo and paraganglioma. But after all this extensive workup, it has found that the only criteria that can be adopted as a sign of malignancy is a metastasis. So WHO has accepted only presence of metastasis as a criteria to stamp it as a malignant pheo. So as from the discussion, so it is now clear that the preoperative differentiation between a benign and malignant cortical tumor as well as medullary tumor is very difficult. That is why the treatment remains same for both of them. So now, until unless you have identified one. So now, what can we do for diagnosis of this tumor? So for diagnosis, we can trace the endocrine hyperactivity, or we can see for the malignant potential, that is by the cross-sectional imaging, or we can just do some particular scintigraphy in especially medullary tumors that will help us to diagnose. So what are the hormonal axes you will find in a cortical tumor? So hormonal dysfunction. If it is a cortical tumor, it can be a hyperglucocorticoidemia that will lead to a Cushing's. There can be virilization. It can be a hyperadrenal aldosteronism. That will cause a hypertension, or it can be a sex steroid imbalance that may cause a feminization in the males. So, having said all these hormonal factors, if we have hormonal dysfunction in 2 or more lines, suppose we found that there is a virilization or Cushing syndrome along with a features of feminization or sex steroid excess. So this, if there is a mixed syndrome, both the 2 or more component of the cortex is hypersecreting or hyposecreting, it's just functioning. So there can be a chance of a adrenal cortical malignancy. Mixed syndrome suggests more of a malignancy than a benign tumor. So this is a suggestion on hints. These are not conclusive, but this will clinch your inclination towards the diagnosis of malignancy. Now, in pheochromocytoma, either if it is an adrenal pheo, then it will be adrenaline which will increase. If it is a paraganglioma, the noradrenaline will increase. So your features will be either postural hypotension, episodic or paroxysmal hypertension. There can be a spell of diaphoresis, tachycardia, feeling of impending doom, and pallor. So the classic triad of pheochromocytoma is headache, palpitation, and diaphoresis. But this triad is truly found in very small percentage of cases. Most of them will have a mixed different syndrome and or a persistent hypertension for long. Now, how do you assess this hormone? Hormonal assessment. So, as in other endocrine dysfunction, when the adrenal gland becomes autonomous, the negative feedback to the hypothalamus pituitary axis is lost and the gland becomes autonomous. It is secreting without the stimulation of ACTH. So the goal of hormonal estimation in cortical tumor will be to find a high level of cortisol in absence of a high ACTH, that is low ACTH with a high level of cortisol. So there are different tests. We can use a baseline plasma cortisol and ACTH. We can have 24-hour pre-cortisol urine. You can have midnight salivary or plasma cortisol. There are different tests, but these all are used in permutation combination depending on which sample is available and easy to use. And if some of them are suspicious, we can go ahead with a 1 milligram dexamethasone. Just a second. 1 milligram dexamethasone suppression test. And this test will establish that there is a excess cortisol and low ACTH. So that will establish your primary hypercortisolism or hormone dysfunction of the adrenal cortex. Now for androgen, you can measure this serum androgen or its precursors like testosterone, hydrotestosterone, androstenedione, etc. Now for mineral, if the patient is hypertensive or hypokalemic, you can go ahead with serum aldosterone. And plasma renin activity. So you can confirm this test further by saline infusion or sorologic test. So I'll not go into the technical details of endocrinology, how to diagnose. Just keep in mind, these are the three hormones and these are the basic tests done to establish this hormonal dysfunction. Now for pheochromocytoma or paraganglionoma, the most sensitive test is a plasma or urinary fractionated metanephrine. So this is the most sensitive and more sensitive than CT or MRI. So if you suspect a pheochromocytoma, you should do this test first. These are the blood or urine based test. And if the value is greater than 3 times of normal, you should highly suspect a pheochromocytoma, provided you have excluded 3 conditions. One is a obstructive sleep apnea. One is a congestive cardiac failure or a tricyclic antidepressant drugs. So these are the drugs which will causes false positive test result to urinary or plasma fractionated metanephrine. If you don't have the facility to this fractionated metanephrine, you can still go ahead with a chromogranin A, because this tumors, medullary tumors secretes chromogranin. So this can be an alternative test if you don't have the facility to do this fractionated metanephrine. Now, after you have assessed the hormonal overwork syndromes, then you can proceed towards your radiological imaging. So in radiology, you have cross-sectional imaging. So you have CT or MRI. If you combine CT plus MRI to detect the adrenal tumor, the sensitivity is around 100%. But very small adrenal adenoma, less than 1 centimeter, can be missed also in CT and MRI. So how do we differentiate between a adrenal cortical adenoma versus adrenal cortical carcinoma from radiology? So usually the adenoma is less than 4 centimeter. It is more than 4 centimeter. These are not very, these are common finding, but these are not absolute things. There can be some change in the size or other criteria also, but more or less this follows this pattern. So adenomas are lipid rich. Adrenocortical carcinoma are lipid poor. These are homogeneous, and carcinomas obviously will be heterogeneous. Obviously, the margin will be smooth, the margin will be irregular. And now the important point, if you do a NCCT of your abdomen, then if the lipid-rich adenoma is there, the enhancement will be very low. It will be less than 10 Hounsfield unit. And then we can tell that this is a lipid-rich adenoma. If there is a enhancement up to 10 to 30 ounce field unit, and still there is other factors are not present for suggestive of malignancy, it can be a lipid-rich adenoma also. But these adrenocortical tumors are lipid poor, so usually their Hounsfield unit in NCCT is high. So high Hounsfield unit. Then comes the contrast enhanced CT scan. If you do a contrast enhanced CT scan, what is the diagnostic or pathognomic feature of adrenal adenoma? Can anybody tell? This was MCQ once upon a time. There is a particular feature of adrenal adenoma, radiological image regarding the contrast administration.
Light bulb sign.
What? No. It will be a rapid enhancement and rapid washout. Can you remember? It will be a rapid enhancement followed by a rapid washout. When you push the contrast, there will be enhancement followed by a rapid loss of enhancement. So how do you measure this enhancement? So if the enhancement is more than 60% of your absolute percentage washout, or more than 40%, these are very technical terms, don't go into these details of this term. Just keep in mind that if it is more than 60% of the absolute percentage washout or 40% of relative percentage washout, that means the high chance that this is a adenoma, not a carcinoma. And if it is slow contrast washout, then there is a chance that it may be a carcinoma. So thus the CTs can help us to differentiate between a adrenal cortical adenoma and an adrenal cortical carcinoma. If you come, whether we can go ahead with a PET scan because it's a metabolic, it shows the metabolic activity, whether it can differentiate it between a adenoma and carcinoma. So unfortunately, FDG PET scan doesn't contribute to differentiate between a adenoma and carcinoma. So it is not routinely recommended for adrenal tumors. If you suspect or you find these signs of a in CT scan of suspicious of adenocortical carcinoma, you should go ahead with the staging with thorax, abdomen, and pelvis CT. Okay. So now, if we come to the radiological diagnosis of your pheochromocytoma or paraganglioma, so other than this cross-sectional imaging, which will be very similar to other adrenal tumors, we take the help of scintigraphies. So the classical scintigraphy, which is used for adrenal tumor, is what is the classical scintigraphy that is used for adrenal tumors? So this is a iodine 123 MIBG scan. And other than this, you can go ahead with the 18 FDG PET or F-DOPA PET. With a different modification, the nucleotide has been changed, the isotope has changed, or you can go for somatostatin receptor scintigraphy. Because this pheochromocytoma paraganglioma also acts as this endocrine tumors where somatostatin receptor uptake is there. So you can use either indium 111 pentatriotide or a gallium 68. Don't go into those details. Just keep in mind that somatostatin receptor scintigraphy is an option to scan adrenal pheochromocytoma or paraganglioma. But all these methods have found very ineffective to scan or to isolate the extra-adrenal paragangliomas. So for extra-adrenal They are very poor. So now the recent and most effective scintigraphy is 68 gallium DOTA-TEC PET CT. All these are used only for adrenal tumors. This DOTA-TEC PET CT has a high sensitivity for extra-adrenal tumors also. Now, whether we should go ahead after the radiology and hormone estimation, whether we should go ahead with a biopsy or not. Usually, biopsy from an adrenal lesion is not recommended because first, there is a high chance of pneumothorax because it located just near the diaphragm, or a hemorrhage within the adrenal, which may lead to sudden adrenal insufficiency. And it also doesn't differentiate between adrenal cortical adenoma from the small biopsy and adrenal cortical carcinoma. So from the small biopsy, you cannot actually reliably differentiate between a malignant and benign tumor. That is why it is not indicated for adrenal tumors, but still you have some ground for adrenal biopsy, especially you are suspecting a secondary tumor like a lung mets. You need to confirm that is a solitary lung mets, or some inflammatory condition like TB. Then you should go ahead with a biopsy, but always should exclude pheochromocytoma before doing a biopsy by doing this plasma or urine fractionated metanephrine. Now coming to the staging, there are different staging system, European, American and other things, but now after this HCC, all the staging system has been incorporated by HCC 8, and now it has been included in our HCC staging manual. So there are 4 stages, and if you look very closely, that if it is a pheochromocytoma, then M1 is a distant metastasis. That is only stage 4. Other than this, any nodal spread or other things is up to stage 3, obviously, like other tumors. So basically, what you have to know, whether it is a M1 disease, that is the only sign that this can be a radiological sign preoperatively that this can be a malignant pheo. Now, coming to the if you do a CT scan for some other indication and you find the adrenal tumor, that is called an incidentaloma of adrenal, how will you proceed? So first you look towards the size criteria. So if it is size less than 6 or it is more than 6 centimeter. If it is more than 6 centimeter, if there is a suspicion of malignancy from the CT, or if there is a hormonal production, then you should not wait to get the diagnosis. So you stage the disease by imaging like CT thorax, abdomen, pelvis, and you go ahead with surgery after obviously controlling the hormone imbalance. Now, if the size is less than 6 centimeter, there is no obvious malignant suspicion and no hormonal overactivity. So what you will do? You will do a NCCT and NNCT and see whether or you can do a chemical shift MRI. And in that, you will see what is the enhancement. If it is less than 10 Hounsfield unit, it is straight cut, or there is a signal dropout in MRI. So it is a lipid-rich adenoma. You can follow up. Now, if it is more than 10 Hounsfield unit or there is no signal dropout in MRI, so what you can do, you will repeat a contrast enhanced CT scan, that is CECT. In CCT, dynamic CCT, you will see for the contrast washout. So if the contrast washout is absolute percentage washout is more than 60%, or a relative percentage washout is more than 40%, again the diagnosis is a adrenal adenoma. Definitely go to the follow-up. But if the percentage is not so, the washout is not slow washout, then what you should do, you further evaluate the tumor by other imaging and other things, either scintigraphy or something like that. And if it looks like a benign, you follow up. And if it is either malignant or hormonally active, you go ahead with surgery. So this is the flowchart for incidentaloma. You will see for the size, suspicious feature on the CT for malignancy and the hormone production. If nothing is, if any one of this is present, stage the disease and operate. If there is no such is present, the size is less than 6 centimeter, you do a CT scan, and that is a non-contour CT scan. You see what is the ounce per unit of the tumor. If it is less than 10 ounce per unit, the chances that it is a lipid-rich adenoma, and you follow up this patient. And if there is a more than 10 ounce per unit, you go ahead with this contrast and CT, see for the washout of the contrast. If it is a fast washout, again it is a adenoma, go for follow-up. It is a slow washout, so investigate further or do some radiological test further to confirm whether there is a suspicious malignant features is there or not, or any hormonal overproduction is there or not. If it is present, you operate. If it is not present, you will follow up. So I think this is clear to all. Any question about this incidentaloma? So now we begin with the treatment part. Treatment, both for the adrenal cortical tumors and for the pheochromocytomas, we have to do a perioperative hormonal control before operating the patient. So first, if it is a hypercortisolism, that is adrenal cortical carcinoma or adenoma, there could be chance of venous thromboembolism, metabolic dysfunction, infection, diabetes, etc. So what you use an adrenolytic agent or anti-adrenal agent, that is ketoconazole or metidopone, to preoperatively decrease the hypercortisolism. And post-operatively, when you remove the tumor, if it is a functioning adrenal adenoma or carcinoma, then there will be sudden adrenal insufficiency just after you remove the tumor, because it was hyperfunctioning and the HP axis, the negative feedback on HP axis is gone. It is an autonomous tumor. Another adrenal gland is not functioning well, and once you remove the tumor, there will be sudden adrenal insufficiency. So immediately after removal of the tumor, you add glucocorticoid to the patient and you taper according to the recovery of your hypothalamus pituitary axis. So these are the two important things. Preoperatively, we'll give some adrenolytic agent, and postoperatively, after removal of the tumor, what you have to do, start glucocorticoid immediately. That is your hydrocortisone or other things. Now for pheochromocytoma or paragangliomas, the perioperative hormonal control is very important. So that will give you hemodynamic and metabolic stability, and it will decrease the cardiovascular complication. So treat the hypertension with alpha blocker. Among the alpha blocker, you have either phenoxybenjamin, or you have prazosin or doxazine. And now you replenish the volume. It may take around 3 weeks to control the beta, to completely block the beta receptors. So then after you have blocked the alpha receptor, you should go ahead to check for whether any tachycardia is there or not. If there is a tachycardia, you add beta blocker only after complete alpha blockage. And you have to also post-operatively and intraoperatively aggressively monitor the BP and rapid react. Yeah.
Volume replenish after 3 weeks is there, no, sir, to completely block. For which block, sir? Of alpha or beta?
Alpha blocker. Alpha blocker, usually it will take around 3 weeks. So it is better if you're planning to for a surgery. So it will take around 3 weeks to for a complete alpha block. So it is better to start this alpha blocker for 3 weeks. And then after then, if the tachycardia is there, then only you will add the beta blocker. Or if the hypertension is not controlled. Usually alpha blockers are potent antihypertensive. If you start using them, there will be control of the hypertension. But just because the hypertension is controlled, you have given alpha blocker for 2-3 days, you should not jump ahead to go to the surgery, or you should not add beta blocker. For 3 weeks, you should give the alpha blocker, and once the BP settles, then you check for the pulses. If the tachycardia remains, you add beta blocker. If there is no tachycardia, there is no need of beta blocker. You go ahead with the surgery with the intense BP monitoring during surgery and take help of the rapidly acting antihypertensive and hypertensives like sodium nitroprusside and other things. Okay.
Okay, sir. Thank you.
And there is a problem in post-op also. Once this tumor is removed, the alpha action is gone. There is a profound hypotension. So at that time, so you have to give fluids and your vasoactive agents, alpha-adrenergic agents, so to keep the BP in the normal level. So post-operatively, there will be hypotension. So that has to be anticipated and prevented before you go ahead with the post-operative recovery. So now what surgery you will do? So if it is a pheochromocytoma of adrenal gland, which is non-metastatic, that is stage 1 to 3, or if it is a adrenal cortical adenoma, that means you are sure that from CT scan it is adenoma, there is no chances of adrenal cortical malignancy, you go ahead with the laparoscopic adrenalectomy. In some bilateral and familial tumors, there is a term called cortical sparing adrenalectomy. This is a bilateral familial pheo I'm talking about. You can spare the cortex and just excise the medulla. That is also called a partial adrenalectomy. That will prevent your postoperative adrenal insufficiency. But if it is a stage 4 pheo, or it is a suspected adrenal cortical carcinoma, let's go ahead with the open approach. Because there can be adjacent lymph node involvement, adjacent organ involvement. It is a very aggressive tumor. So it's better to go ahead with a open approach. Now, that will help to violate the capsule of adrenal cortical carcinoma. Or if it is a locally advanced, it will help out to do a multi-visceral section. Suppose it has involved the kidney, you can go ahead with an nephrectomy in the same sitting. So en bloc removal. So en bloc removal, or to decrease the tumor spillage in these tumors, because adrenal cortical carcinoma is a very aggressive tumor, it go ahead with a open approach. Now, whether lymph node dissection is needed, that is retroperitoneal lymph node dissection, that is doubtful. But if you are achieving R0 resection, so it's better to go ahead, especially in a setting of adrenal cortical carcinoma, go ahead with a RPLNG. So if it is R0, you are sure that you are removing all the tumors from the primary site, you can go ahead with a RPLNG. Now, if there is a positive margin or spillage or a R2 margin, you can go ahead with a resurgery, or you can add radiotherapy to the tumor bed. And in adjuvant therapy, you have, for adrenocortical carcinoma, you have your adrenolytic agent that is called METO10. So you'll add METO10 around 3 months after the surgery, and it will continue up to 5 years. So that is the adrenolytic agent that is you always added along with adrenalectomy after a adrenal cortical carcinoma, or you can use a tumor bed radiotherapy to control the microscopic diseases. And if there is a recurrence, you should go ahead with surgery only if the DFS is more than 12 months. Means if there is a recurrence within 1 year, it is better not to reoperate. If it is a localized recurrence after 12 months, you can go ahead with a re-resection. So how will you follow up? You will follow up with the hormonal estimation for FIO every 2 weeks, then 6 weeks, 3 monthly. And also for this adrenal cortical carcinoma, you can, if it is a hormonally functioning one, you can go ahead with the hormonal estimation or a periodic radiology. Because this adrenal cortical carcinoma is much more aggressive than your FIO, so there is a chance that they will come back soon after surgery. So now the last part will be our palliative treatment part, that is a metastatic adrenal cortical carcinoma and FIO. So what will you do in a metastatic setting? So if the goal is in a stage 4 adrenal cortical carcinoma is a palliative one. If there is a limited meds, some recommend resection, some recommend METO10 along with systemic chemo with etoposide, doxorubicin, cisplatin, etc. And if they are not responsive, you can try it with novel therapies like anti-VEGF or your EGF or anti-EGFR therapies, cetuximab, bevacizumab, etc. And now, if there is a pheochromocytoma that is metastatic, what you will do, you'll see whether they are symptomatic or whether they are asymptomatic. If they are asymptomatic, you follow up, wait and watch. If they're symptomatic, you have to control the primary tumor somehow. So you can go ahead with the multivisceral surgery. You can go ahead with the external beam radiation ablation, PVRT. You can go ahead with radiopharmaceutical like MIBG or somatostatin receptor scintigraphy ablation, or you can add some systemic chemotherapy. So that is your other than this, if these are not possible, you can try some RFA or some ablation technique or TACE. So the concept is in a palliative setting, if it is a adrenal cortical carcinoma, just give some chemo or METO10, etc. But in FIO, you have to look out whether it is symptomatic or asymptomatic. If it is asymptomatic metastatic FIO, you don't have to do anything. If it is a symptomatic FIO, you have to decrease the tumor bulk. You have to remove the main source of the tumor, main tumor. So you have to either do a multivisceral resection or a radiation or some ablation technique, radiofrequency, or you can use some scintigraphy directed therapy, or some systemic chemotherapy, which are not very effective in my adrenal tumors. So this is in gist about the adrenal tumors. So other than this, some in adrenal metastatic setting of this adrenal cortical carcinoma, if it is a symptomatic one, some anti-hormonal drugs like spironolactone or mifepristone may be effective to control the hormonal imbalance. But as a whole, mitotin is commonly used for adrenal cortical carcinomas, and for FEO, you look for the symptoms. So now that completes the discussion about adrenal tumors. I think it is a little bit complicated because of two types of tumor. One is a medullary and one is a cortical tumor. So just keep in mind that FEO is a comparatively less aggressive tumor, but has a more hormonal disturbances which have impact on cardiovascular and other system. On the other hand, cortical carcinomas have these are advanced tumors. These are very aggressive tumors, so they may have mass effect and other effect rather than having this hormonal symptom. So with this, I think Shilajit, we can close. Any question is there?